Hello, everyone. My name is Professor Kristen Hernandez, and welcome to your basic electronic fetal monitoring course. I've been a nurse for 11 years. I graduated from San Diego State University in 2011. All of my career has been spent in the specialty of labor and delivery. I'm currently in school pursuing my master's degree in nursing education with a planned graduation date of the fall, as well as I am an adjunct professor for Miracosta College, and I teach clinicals to LVN students and RN students in the labor and delivery setting. By the end of this course, I expect you, the nursing student, to be able to identify the importance of the use and competency of evidence-based practice, as well as to be able to identify characteristics of an electronic fetal monitoring strip, including baseline variability, the presence of accelerations, the presence of decelerations, and correctly assign the appropriate fetal monitoring category. You'll also be able to identify intrauterine fetal resuscitation measures by the end of the course, as well as identify all decelerations, including earlies, variables, and late decelerations, and to be able to identify their associated etiology by the end of the course. So just to brush up on the importance of the use and competency evidence-based practice, I'm going to pull up a video for us that's going to detail a little bit more about evidence-based practice. This video was shared online by Utah State University, and so you will notice that they reference their personal school library. Specifically, we have our own school library that you guys are well versed in using, and so you can utilize the same skills and tools that they talk about, but with your own university library.
As a practicing nurse or health professional, you'll need to know about evidence-based medicine and recognize where information falls on the spectrum of evidence-based, in addition to likely using evidence-based practice in class projects. As a review, what is evidence-based practice? There are three main elements. The first is research. What do the research articles or studies say about best practices for addressing or treating a disease or condition? The second element are patients and includes their values and preferences. And the third element is the clinician taking into account their experiences and judgment. There are many levels of evidence in research based on how rigorous a study is. The studies become more rigorous and reliable or use the highest level of evidence as you move up the evidence pyramid, from case studies to randomized control trials to systematic reviews. Some things that are not evidence-based are information from websites such as Healthline, the Mayo, or Cleveland clinics. The information on these types of websites is sometimes produced by doctors or others working in healthcare, but is geared toward the general public and not health practitioners, and it has not been reviewed extensively enough to be considered based on the best established evidence. How can you use evidence-based practice? If you need to find information about a condition or learn about suggested treatments, you can look up research that has been officially reviewed by experts and meets specific criteria. Nursing Reference Center Plus through the library website is often a good place to start. Many of the articles are a summary of best practices and represent evidence-based medicine. The Sentinel database, also through the library website, is a good option for more in-depth research. Not all the articles will be research papers, but you can evaluate them to choose the best options or limit your results to only academic journals. For example, let's say you're researching osteoporosis for a presentation to senior citizens. Looking at resources in Nursing Reference Center Plus will help you find evidence-based sources for your presentation, so you can be more confident in the information you share with your audience. If you need help finding sources or with research help in general, you can always ask a librarian. Go to library.usu.edu and click on Meet with a Librarian for more information.
My wife's like, what'd you do after,
Sorry about that. That is our video on use and evidence-based practice. Let's just switch back over to our PowerPoint. Perfect. And so if you guys are looking for more evidence-based information or looking to research more about basic fetal monitoring, Up to Date is also an amazing resource where I've actually found a lot of the content for this presentation. And so there is a lot more in-depth information about fetal monitoring other than just the basic overview that we will be going over today. So please check that out if you're interested or you're needing more of that content. So the purpose of fetal heart rate monitoring is to assess how well the fetus is doing in the intrauterine environment. So how well is this baby doing inside of the uterus? Are they thriving? Are they surviving? Are they doing well? Or are there interventions that we need to do in order to help this baby stay thriving in the intrauterine environment? Fetal monitoring can also assess the uterine contraction pattern in association with the progress of labor. So this gives us a lot of information on how often the mom is contracting and if that is a pattern that we are looking for, and if that's a pattern that we are associating with an active labor pattern and expecting the mom to be making progress in her labor. Here you can note the external fetal monitoring equipment. So at the very top, we have, of course, our fetal monitor. Every facility, their fetal monitor is going to look different, but the facilities that I've worked at, we've used this exact GE Healthcare fetal monitor. You'll utilize fetal monitor paper, which records the fetal monitoring wavelengths as well as the uterine contractions for easy reference. And at the bottom, you can see the TOCO dynamometer as well as the Doppler. So the TOCO, for short, is what we call it. That is going to measure your uterine contractions. It's only going to measure the frequency and the length of the contractions. It's not actually going to measure the true strength of the contractions. And the Doppler, which is to the right of the TOCO, is going to measure the fetal heart rate. And there are limiting factors to the Doppler, which include maternal hepatus, which can interfere, as well as the positioning of the baby, which both of them can interfere with the ability to monitor the fetal heart rate from the external environment. Wherein lies the internal fetal monitoring equipment. So at the top, you can see an example of a fetal scalp electrode. So this is an internal monitor that goes inside and actually inserts up into the very thinnest layer of the fetal scalp. And that is then able to actually pick up the electric activity of the fetal heart rate and give us a much more accurate presentation of what the fetal heart rate is doing. So if you're having much interference or difficulty monitoring the fetal heart rate from the external environment, we then switch to the fetal scalp electrode. The other one is the intrauterine pressure catheter, also known as the IUPC. So this pressure catheter can go internally into the uterus in order to measure the true pressure and the true strength of the uterine contractions. This will also tell us the frequency and duration of the contractions, as does the external fetal monitor. But again, this adds the extra element of being able to determine the true strength of the contractions. The intrauterine pressure catheter also gives us the opportunity to do other intrauterine resuscitation interventions, such as the amnio infusion, which helps put water into the uterus to help relieve cord compression, which we'll touch on in a little bit. So as far as the placement of the equipment, the Doppler, which is again the instrument that helps to measure the fetal heart rate, goes over the fetal back externally. So wherever it is that you're finding the fetal heart rate and picking it up is typically over the fetal back, because that's where the heart is in the fetus. And a lot of times it's not exactly clear where you're going to place that Doppler. It's just kind of a trial and error process of moving that Doppler around. The TOCO is placed on the fundus, which is located at the top of the uterus. And so the nurse will have to palpate where the top of the uterus is and where the uterus is getting most firm during a contraction. And that is the place that you want to place the TOCO. The fetal scalp electrode we talked about is placed at under the very most thinnest layer of the fetal scalp on top of one of the scalp bones. And the area to be avoided is the fetal suture. because that is the open area, right, between the scalp bones, where underneath the brain could be exposed. So we want to avoid that area and find the hardest part and the widest area of the fetal scalp to place our fetal scalp electrode. And then the intrauterine pressure catheter, again, is placed up inside the uterus. So right next to the baby's head, not on it or in it, right next to it inside the uterus. We touched on this already. The uterine contraction monitoring is going to measure the frequency. The frequency of the contractions are counted. It's going to be a range, and it's counted from the beginning of one contraction to the beginning of the next contraction. And on my next slide, I have an example of exactly how to calculate that, so it'll make a little bit more sense. The duration of the contractions, though, are counted from the beginning of one contraction to the end of that same contraction. So the frequency is going to tell us how often the uterus is contracting. Is it every 2 to 3 minutes, every 2 to 10 minutes, for example? And the duration is telling us how long one contraction is. So is it 60 seconds? Is it 80 seconds? Is it 40 seconds, for example? So right here, we can see what uterine contraction monitoring looks like. So just to give you guys an idea, right here, up here is the fetal heart rate monitoring. And the lower boxes is the contraction monitoring. And it's always going to be the same on every fetal monitoring system. You're going to have the fetal heart rate up top, and you're going to have the contraction monitoring on the bottom. So as I was talking about, we have 4 contractions that we can look at and compare. But the frequency is going to be counted from the beginning of one contraction to the beginning of the next contraction. And when you're doing a fetal heart rate assessment, which are typically done every 10 to 30 minutes, the contraction frequency is going to be noted in a range. So you're going to measure the 2 contractions that are up here closest together and the 2 contractions that appear furthest together. So we can count these 2 because these 2 look the closest together. So right here, and every thick bold line is 1 minute. Okay, so from the beginning of this contraction, which magically starts on this bold line, is going to be 1. So from here, I lost my mouse. From here to here is 1 minute. And then from here to the beginning of the next one is about 10, 20, 30 seconds. So that's going to be 1.5 minutes apart right here. And then from the beginning of this contraction, this one starts in about the middle of these bold lines. So we can count this first section as about half, right? So half, and then this would be the end of the second bold line. So another half. So this is about 60 to 70 seconds, right? 10, 20, 30, 40, 50, 60, 70 seconds long. And then as far as the frequency, we're going to go from 1/2. So from here to here would be 1 in the middle, right? From here to the middle of the second bowl line would be 2.5. So 2.5. So our frequency range is going to be 1.5 to 2.5 minutes. Okay. And then as far as duration, again, we already counted this one right here. So this was 10, 20, 30, 40, 50, 60, 70 seconds. And then let's look for our, what appears to be the shortest contraction, which would probably be this one right here. It's going to be 10, 20, 30, 40, 50, 60 seconds. So our range would be 60 to 70 seconds for the duration of the uterine contractions. Now switching over to the actual fetal heart rate monitoring, one of the first things that we're going to assess is the fetal baseline. So the normal baseline would be a heart rate that stays between 110 and 160. So the average of what the heart rate is over a 10 to 30 minute period, we want that number, that average number, to be within the range of 110 to 160. Okay, so the other thing is that the fetal heart rate is going to be measured in increments of 5 always. So you're never going to see a fetal heart rate that's 147. You're never going to see a fetal heart rate that's 123. It's always going to be either rounded slightly up or rounded slightly down or spot on, just depending on where the baseline rate stays. So for example, it'll be 145 beats per minute or 120 beats per minute. But that normal baseline rate is always going to be between 110 and 160 beats per minute. Now, there can be fetal tachycardia and there can be fetal bradycardia. So fetal tachycardia is a baseline that is greater than or equal to 160 beats per minute for greater than or equal to 10 minutes. Okay, so any baseline change is considered a baseline change when it's been greater than or equal to 10 minutes. And as far as fetal bradycardia or a low fetal heart rate is going to be the baseline that is less than 110 beats per minute for greater than 10 minutes. Okay. So for example, we have this strip right here. Okay, so as you can see, there are definitely fluctuations and undulations in the fetal heart rate. But what we are looking for is the average, or where the fetal heart rate stays the most of the time throughout the whole strip that you're looking at. Okay, and so right here we can see it's 120, 130, 140, 150. So every small line, like you can see right here, are going to be 10 seconds. So we can see our average fetal heart rate across this whole strip that we're looking at. It lies right in this area. So this is 120, 130, 135, 140, 150. I would say that the baseline for this strip is about 135, right in here. Okay. Accelerations. Accelerations are actually a good thing. They are a great thing. Okay, these are very reassuring. An acceleration looks like an abrupt increase in fetal heart rate greater than or equal to 15 beats per minute for greater than or equal to 15 seconds. So we call them 15 by 15s. So if your heart rate is at a baseline and it only goes up by 10 beats from the baseline for 10 seconds, that is not considered an acceleration. It has to go up at least 15 beats from the baseline for at least 15 seconds. And why are accelerations reassuring? Because they're associated with fetal movement, okay? They're also associated with knowing that the fetus is not in an acidotic state. And accelerations represent an intact central nervous system. So here is an example of some beautiful accelerations. We already learned about baseline, right? Here's our baseline. So our baseline, this is about 120. Our baseline is about 145 to 150, 145. Let's call it 150. Okay. So that means if our baseline is 150, we have to determine that first. Then an axle has to go up at least 15 beats per minute from the baseline, which means that they would have to go up at least to 165. And if this is this right here, it's 180. Okay, so if this is 150, this line is 180. I'm sorry, we can't see it very well. But that would mean that from 150, the acceleration would have to go up to at least 165, which is going to be right in here. So this one definitely does. Okay, and then again, right here, this goes all the way up to 180, but it only stays at 180 for a short period of time, but it hits 165, which is right in here, for more than 15 seconds. So again, that's another accel. And then over here, this one is the exact same thing. It goes all the way up to even 185, but it hits about 165 and stays there for longer than 15 seconds. So all three of these upright, abrupt increases in the heart rate are considered accelerations. And again, those are very reassuring. Okay. The next thing that we look at is variability. So variability is going to give us an indication of what the fetal oxygenation status is. This slide is kind of put together a little bit backwards, but just so that you know, right here, this moderate variability, that is our goal. We want moderate variability. Always. We can have minimal variability for short periods of time. We can even have absent variability for short periods of time. But our goal is always moderate variability because this is the best indicator that our fetus is well oxygenated. So what moderate variability looks like is right here in the baseline, that beat to beat change lives between 6 to 25 beats per minute. So from one beat to the next, over and over on average, we're having a fetal heart rate change of 6 to 25 beats per minute. So it looks like this nice, squiggly, wonderful, reassuring line. Now, in comparison, over here is the minimal variability. So minimal variability is going to look like a beat to beat change of less than 5 beats per minute. So you can see a vast difference in the beat to beat difference. So this is much more undulating in a good way versus this is much more refined of a beat to beat change. Okay. And the worst, the one that we never really want, and that the variability that we're not really going to tolerate is going to be absent variability. So right here, you can see it's pretty much that beat to beat change is nearly undetectable. You could pretty much take a pencil and draw out this line. This variability is definitely going to be an indicator for intervention, because this shows us that our baby is novel, oxygenated, and potentially acidotic, and we need to either fix this or change the fetal environment. And then finally, marked variability. This is probably the variability that we see least often, and this is going to be a change in beat to beat variability greater than 25 beats per minute. So you can see that sharp, vast difference between beat to beat. Marked variability is not bad and it's not good. It just is something that we need to know and be aware of. A lot of times you'll see marked variability as the baby is recovering from a deceleration. And so that's when it typically will present itself, but it's definitely something, if I start to see marked variability, I'm going to take note of it and I'm going to watch that strip very closely, because either something just happened or something I can predict is going to happen. So let's take a little deeper dive into factors that affect variability. So for minimal or absent variability, if that baby is premature, we have a little bit more grace as far as the variability goes. We don't expect that baby's central nervous system is as developed as a full-term baby. Also, babies do go through sleep cycles, so they can sleep off and on, and sleep cycles generally last about 20 to 40 minutes. And so in a sleep cycle, we will typically see minimal variability. If there are any congenital anomalies present, any fetal arrhythmias, we may note some minimal variability, minimal or absent variability. And again, variability is indicative of oxygenation. So if there's hypoxia, which leads to acidosis, that may present itself as minimal to absent variability. There are also medications or drugs that we give that can affect fetal variability. Narcotics, believe it or not, we do give narcotics in labor. A lot of times we're giving fentanyl or morphine to moms for pain control, and that can affect variability. If a patient is put under general anesthesia, the general anesthesia can reach the fetus in the uterus, and so that can affect the variability. We give ephedrine to moms in labor if their blood pressure is too low, and we give magnesium sulfate to moms in labor, oftentimes when their blood pressure is too high. And so those things as well can affect variability. What are interventions when we're having minimal or absent variability? Number one, we have to assess the fetus and consider what's going on. Is this potentially a sleep cycle? Did we just give this mom any of these medications that we just talked about? Okay. And then we can also do interventions to help try and retrieve that moderate variability by doing fetal scalp stimulation, which is performed by a cervical exam and rubbing the fetal scalp from the inside to try and stimulate some kind of activity or response. And there's also acoustic stimulation, which is a little buzzer. It's a little vibrating buzzer that we place on the maternal abdomen that gives a vibration, and the baby can hear it intrauterine, and that can stimulate the baby to move. Okay. And if the reason is hypoxia, if that is why we're having minimal to absent variability, we need to do our best efforts to improve oxygenation. So that includes repositioning the mom as well as giving her more hydration or IV fluid bolus. Both of those can increase the circulation to the uterus and the fetus, as well as, which in turn improves the oxygenation. This acronym, VEAL-CHOC, is used to help us associate and understand the different intrauterine etiologies that cause the different decelerations. So a variable is caused by cord compression. An early is caused by head compression. Accelerations are okay. And late decelerations are caused by placental insufficiency. So that is a really quick and easy way to compare and associate what exactly are causing our decelerations. So an early deceleration, like we said, is caused by head compression. So oftentimes we're going to see early decelerations when the baby is moving down the pelvis or the birth canal and the head is starting to get squeezed. We're going to see these subtle, gradual, unsymmetrical decelerations in the heart rate. These are relatively benign. They don't necessarily indicate intervention. It's just something to know and to give us a bit more information about what's going on with the fetus inside the uterus. Variable decelerations. Variable decelerations are associated with cord compression. So oftentimes in the uterus, the umbilical cord can be compressed, which reduces the blood flow to the fetus, and that's represented in a variable decel. So the notable thing about this is it's an abrupt onset to the nadir, which is the most furthest point away from the baseline of the deceleration. Okay, so it's going to be a nice, quick, fast slide. And part of the criteria is for the fetal heart rate to reach at least 15 beats below the baseline, which you can see all of these are representative of. A late deceleration is caused by placental insufficiency. So that is when the placenta is not providing adequate blood flow and fetal circulation to the fetus. Okay? These are much more subtle and much more gradual. So it has a gradual onset of greater than 30 seconds. What makes late decelerations different from early decelerations is that they start after the onset of the contraction. So early decelerations mirror perfectly the contraction because the contraction is what's causing the head compression. As far as late decelerations, you're going to notice that they start after the start of the contraction. Prolonged decelerations. Prolonged decelerations are decelerations that last longer than 2 minutes. The baby's heart rate goes down, and you as the nurse, your heart rate goes up. Okay. So prolonged deceleration, sorry about that, lasts longer than 2 minutes. Ideally, they're going to come back up to baseline and recover. If they continue, we are moving towards an emergency C-section. Okay. If you have a deceleration that maybe is lower than the baseline, so greater than 15 beats towards the baseline. So if our baseline is 150, say they come down to 135, but they stay there for longer than 10 minutes, then that's a fetal heart rate baseline change. We got 10 more minutes. And therefore there's no intervention needed. But if it's going to go much lower than our normal baseline, which is 110 to 160, and stay there, again, that's an emergency, and we're going to be moving towards the OR. So interventions specifically for each type of deceleration. So for variable decelerations, we're going to reposition our patient because remember, those are caused by cord compression. So we need to try and move the baby off of the cord. So reposition, hydration. We want to discontinue the oxytocin if the patient is on any, so that we can decrease the strength or frequency of the contractions and give the fetus a break. We can also perform a cervical exam. Potentially, the umbilical cord can come out first before the baby's head, and that is called a cord prolapse. Okay, so we want to check for that and make sure that there is not a presenting cord. And then we also need to notify the provider that these are happening. The providers must be aware of variable decelerations. And then the other thing that I had mentioned earlier when I was talking about the IUPC is for variables, we can place an IUPC if there's not already one in place. And we can instill normal saline back into the uterus to provide a cushion for the fetus away from the cord in order to help relieve some of that pressure on the umbilical cord. For late decelerations, interventions specifically for these types of decelerations are repositioning, hydration, discontinue the oxytocin again, notify the provider, and then also we need to assess what potentially could be inhibiting the placental circulation. If the mom's blood pressure has dropped significantly low for her and she's having hypotension, we need to be able to treat that blood pressure and increase her blood pressure in order to increase the fetal and placental circulation. Prolonged decels, specific interventions. Again, we're always starting with repositioning and hydration. Again, what is the cause? If it's hypotension, we need to treat that. We need to notify our doctor, discontinue the oxytocin. And then also we can give a medication called terbutaline, which helps specifically to relax the uterus, to give that baby a break from contractions, which could be potentially clamping off the circulation, causing the prolonged heart rate deceleration. So as we monitor our fetal monitoring, every time we do a fetal monitoring update and chart it in the computer, we're also determining and assigning a fetal heart rate classification or category. And there are 3 categories, category 1, 2, and 3. Category 1 is normal, absolutely normal, nothing to do there. Category 2, it's indeterminate how well the baby is doing. Baby could come out totally fine. Baby could come out not fine. It's definitely just a gray area. And category 3 is abnormal. The baby is not doing well, and we absolutely need to do some interventions to move towards delivery because the baby is not doing well in its intrauterine environment. So a little bit more specifically about the categories. Category 1 is predictive of a normal acid-base status, and that is what we want for our fetuses. We want them to come out with a normal acid-base status and not acidotic. So indicative of category 1 would be a fetal heart rate tracing of moderate variability, a baseline that remains between 110 and 160, no presence of no presence of any late variables or prolonged decelerations. Any presence of early decelerations are okay. They can still be a category 1. And accelerations are good, but you can still be a category 1 without accelerations, even though those are very reassuring. Category 2, again, is indeterminate of abnormal acid-base status. So this baby could come out acidotic or could come out not acidotic. It is too gray of an area to tell. So category 2 indicators are minimal variability, absent variability without recurrent late decelerations. Marked variability would be considered category 2. Recurrent variables with minimal or moderate variability would also be category 2. Any prolonged decelerations that recover or recurrent late decelerations with moderate variability in between, again, are category 2. So gray area. We should be doing interventions to help resolve these things that are causing the category 2, but it doesn't necessarily mean that we have an indication for an emergency C-section or an alternative route of delivery. Now, category 3 is very scary and absolutely needs to be addressed. It indicates abnormal acid-base status, so we can almost guarantee that this baby will come out acidotic. This requires prompt assessment and intervention. Absent variability and category 3 includes absent variability and the presence of recurrent late decelerations, recurrent variable decelerations, and bradycardia. So that would be a prolonged decel that does not resolve. Here's an example of category 1. You can see we have a normal baseline, moderate variability, and accels. Here is an example of category 2. We have minimal to moderate variability, but we have recurrent variables. And so that because of that, this indicates that this is a category 2 strip. Here's a category 3. It is very clear that we have absent variability. There is no variability. There is no B to B change. You could draw that with a pencil. And then also with every single contraction, we have recurrent late decelerations. These decelerations are happening after the contraction. Coupled with the absent variability, this is a category 3, and we would absolutely be moving this patient towards the OR to have an emergency C-section. So that is it for now. That is your basic fetal monitoring. And there are more classes, including intermediate fetal monitoring and advanced fetal monitoring, that you will take further into your career should you decide to go the route of labor and delivery. But this definitely covers all your bases, is going to help you to understand what you're seeing when you're in the clinical setting, when you're watching and working with your nurse to interpret fetal monitoring strips. And that is it. If you have any questions, please feel free to email me or message me, and I am happy to help. Thank you, everybody, for your time. And I will see you next class.